Hello, my name is Kelly Callahan. Welcome to the infirmary. I've been here since October of 2018, and I've been nursing for a long time. I started off in pediatrics, I've done some med-surg, done cardiac. Most recently, I worked at the University of Arkansas Flint. I taught high school students that were concurrently enrolled in the LPN program. So that was a very tough crowd. So we're going to move right into hospital value-based purchasing and nursing quality. So has anybody ever heard of hospital value-based purchasing?
Yes.
You have. Oh, good. All right. Okay. Yes. Here's a quick little video.
Value-based purchasing.
We're waiting now.
In the Hospital Value-Based Purchasing Program, or VBP, CMS is paying those from an inpatient perspective payment system using a value model instead of a straight fee-for-service model. So CMS will blah, 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 quality outcomes, blah, 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 patient experience, blah, 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 affordability, blah, 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 as well as population health and admissions.
Hey, did you guys understand a word Mike was saying? I mean, if that what an MBA does to you, I'm not even sure he was using human words there for a while.
Sorry, Jamie. I have no idea. I was almost asleep. I worked last night, and I can't think straight without my coffee.
I wasn't really listening to Mike either, but let me try to explain value-based purchasing to you.
Finally, let's hear it. Thank you, Kevin.
Since the government is learning that money doesn't grow on trees, it has changed the way it pays healthcare organizations and providers. The payment program is called value-based purchasing. Value is made up of quality, the patient experience, and the cost of care. Providers and hospitals have a portion of their work paid based on their patients' outcomes, instead of purely how many patients they treat. When patients come to our facility, they are asked to fill out a survey about their experience. Those survey results are reported to the government. Each person that has an interaction with our patients has the potential to impact our patient experience scores.
Hey Kevin, we're also working on improving our costs. I've been making sure I'm not ordering unnecessary tests, which can add to the cost of care.
So now that we've established what value means, let me talk a little bit about how the payment for value works. The government payers withhold a portion of payment to providers and facilities and set it aside for the value-based purchasing program. Hospitals and providers can earn the value money back by achieving certain value measures related to quality, patient experience, and cost of care. But if the goals are not reached, there could be tens of thousands or even hundreds of thousands of dollars that we will not be paid for. For example, if the hospital is reimbursed $10,000 for one patient's medical care and we do not meet our goals, we will lose 1 to 2% or $100 to $200. Now multiply that by all of our patients. Losing this money affects how we can reinvest in the care we provide for our patients and families, such as new technology or adding staff. Many of these value measures are also available on the Hospital Compare website. You can see how your own hospital performs compared to others. At the end of the day, value is what our patients deserve. Our payments are just changing to reflect that. If each person strives to do their best and gives every patient the care and kindness they would wish for their own family, we will be closer to maximizing value. We can all play a role in improving value by giving the best care to our patients each and every day.
So we can all make a difference. Are you guys ready?
We're ready.
Yeah.
All right. So as Kevin explained, Medicare's payment systems to the hospitals, we get reimbursed for the quality of care that we deliver. All right? Patient experience, when the patient leaves the hospital, they get a scanning survey on how well we treated them, how nice we were. Following best practices, like we want to remove the urinary catheter just as soon as we can. We don't want to leave it in forever. We don't want them to get an infection. And all of this stuff is linked to the hospital quality data report. So, all right, so this says, how does the value-based purchasing program measure hospital performance? And these are some of the ways. Efficacy, safety, experience of care, and clinical outcome. Those are some of the areas that are focused on that scanning survey. All right, so this is another example of the survey for clinical care. Like when we have a patient that comes in for maybe pneumonia, we want to get them well, and then we want to get them home, and we want to keep them home for 30 days. If we don't want them to come back, because if they come back within 30 days, that means we didn't do our job. That means we missed something somewhere, and we probably will not get paid. Just like one of the big things on the survey is the communication with nurses. Are the bedside nurses, are you guys talking to your patients? Are you explaining, doing your AIDIT? My name is Kelly. I'm going to be your nurse for today. Your diagnosis is pneumonia. This is what you need to do. So those are things, all of those things are questions that they ask. And we want them to be able to say, we were always communicated with. Our room was always clean. In one of the presentations you heard about the teletracking, we want them to be able to say that my room was always clean. I was always moved from one location to the other in a timely manner. We want to make sure that our Class C, coli, and all of those infections are reduced. So we just want to remove things as fast as possible. All right, any questions about this screen? All right, so as she said, together we can all make a difference, all right? It takes all of us. It takes the nurses, it takes the PCTs. We all have to work together as a team. All right, nursing quality. All right, so all of these actions can impact their outcomes. So when a patient comes in and we have falls, pain, high restraints, body flaccid, those are our indicators of how well or how poor we're doing. So it's important to watch those. All right, so on every unit there should be a dashboard. Every unit should have one of these, and it should tell you, like, every morning you should have a huddle, and you should be able to see, like, for the past week, we've had 0 falls. And another unit might say, well, for the past 2 weeks, we've had 0 falls. One floor might say, well, last night we had a fall. So they're going to be able to go over the CLABSI rate, the CLADI rate, and there is one floor on this unit. They're going on year 1 for 0 CLADI, and for year 2 with 0 CLABSI. And I think they should applaud that, and they should really be recognized, because that's a lot of hard work to make sure they stay at 0. But those are all the things that we look at. All right. So, when we get a new admission, we want to make sure that we do their Morse Ball scale and the ABCs. And we always want to look at the environment. So as a nurse, when you go in the room, you want to check and see, is there any alcohol swab or any piece of napkin, anything on the floor, anything in the environment that could cause them to trip. We want to keep that picked up. We put our patients on fall risk based on their fall score. Fall interventions are in place throughout the admission. So if I get admitted to the hospital and you guys assess me and I'm a medium fall risk, I will be a medium fall risk until I'm discharged. Discharge patients don't fall risk until they're safely transported out of the facility. All right, so when you guys do the care rounding, the nurses are either going to do even hours and the PCTs are going to be on as per unit. Some units have the nurses do on and PCTs do even. So just ask your unit what they do. But when you make that care rounding, ask them about those 4 Ps. Do they need pain? Are they having any pain? Do we need to take care of it? Do they need to be repositioned? What about potty? Maybe, because a lot of times, are they gonna ask to go to the bathroom? Probably not, but if you say, it's been an hour, let's go to the bathroom, they're more likely to say yes. Do they have their personal items? All of our patients, you guys know this, they want their cell phone, maybe they have hearing aids, they want those hearing aids, even if they're not gonna wear them, they want them close to them. And we have those clear personal belonging bins. Those things are cheap, and you can put the patient sticker on there. And then, like, if she's got glasses and a cell phone and her charger, you can put it all in there. If you need a second one, go get a second one. Get another sticker. Keep those things. If they have their earrings and for some reason they didn't leave them, they didn't send them home, put those in there. And then maybe she wants to wear them, maybe she doesn't. I'm just looking at you because you're right there on the front row. Maybe she's going to be my patient for the night. But ask those things. So everybody's going to have universal fall precautions. All right. So when we talk about universal fall precautions, do you guys all understand what that is? Mm-hmm. Okay. So we want to orient people to the physical layout of the room. And the best way I know to explain that is like, how many of you guys have ever stayed in a hotel room and you kind of wake up at night and it's like, where am I? Mm-hmm. Well, wait, this is not my bed. Well, think about that for your patient. They wake up during the night and it's like, where am I? Mm-hmm. Where's my bedroom? This is my bed, but it's not mine. Where's the bathroom? And as they try to get up there in the night to go to the bathroom, that's when they're going to fall. Mm-hmm. So make sure the call light's within reach, make sure the side rails are up, keep the bed in the lowest position, keep the floor clear, and because as we're working, we drop things, just pick it up. Any personal items, if that appropriate footwear, the non-skid socks, keep that. Any lines and drains, keep those secure, and then do that hourly rounding. Okay, this is the Morse Fall scale. You've probably all seen this in nursing school, but this is what we use here. And it's just a history of falling, yes, 25, no, 0. And then it explains it. Has the patient fallen during admission or within 3 months? That's a yes or a no, and that's how you get to the history of falling. And you guys will have these on your unit. It's in the Cerner charting. So this is how you come up with your score. Mental status, does not understand limitations. Are you able to go to the bathroom alone or do you need assistance? That's how you get to that yes or no. Any questions? Yes, ma'am.
Who's responsible for doing the fall scale?
That is the nurse's responsibility. Now the PCT may report something to you, and you should be aware of that. But it's a good idea for the PCT to go ahead and report it. But it is the nurse's responsibility, the RN's responsibility.
Can the PCT see their score in Cerner and have an idea about how severe of a risk they are?
That is a great question because on the communication boards in the room, those are being changed, and the nurses are going to write their Morse Fall scale on the board and then explain that to the patient.
Okay.
So they're going to start doing more teaching. The nurses are.
Okay.
So yes, those instead of just saying, "Well, you're a false risk score of 40," and you don't know what that means, the nurses are going to start teaching the patients and the PCTs. I'm sure. Yes, ma'am.
Okay, so I wrote this one down. So
You wrote down a question. Okay.
So when you were talking about the patient comes in and they have a fall risk assigned to them, and that stays with them throughout the hospitalization. What if they go to surgery or something, and now that fall risk is now modified?
If I'm your nurse and you come in and I admit you, I'm going to do your Morse Fall assessment and your ABCs and whatever score you get. And when you leave and you go to surgery and you come back, I've got to do this all over again. And then you may have a new score. You may be higher, could be lower, but you're probably going to be higher because you had anesthesia. So I would expect that you would be higher. If you fall while you're in the hospital, have to do this all over again. And then you're definitely going to be higher because history of falling. Yes, patient fell on my watch.
Yeah.
And I also have to write an IRIS report. That's not covered fully in this lecture, but I'll try to notice before. So I'm assessing your fall status on admission, anytime you leave the floor, anytime you fall, which I don't like for my patients to fall because it's just a long charge. I want someone to take good care of you. All right. And then we do the ABCs. People 85 and older, they get an A. There's the bones, coagulation. This place is in a higher category. I mean, like when the teletracking video, someone that's 100 years old, well, that person definitely gets an A, but they may also have osteoporosis. I don't know. I don't know that person that's 100. I don't know if they're on any coagulations. I don't know if they're had any post-surgery. Now, my mother, she's 82, and she's, so really, she doesn't have any medications. She doesn't use any anticoagulants. She doesn't have any underlying scores. So, clinical conditions. She scores kind of low on this, believe it or not. All right, so this is back to, this answers your question again. So we assess and reassess on admission every shift with any change of condition, change in level of care after a fall event, or upon return to the unit. Does that help?
That's perfect.
All right. Now, we also implement universal precautions. We use the yellow armband, the door signage, and it says a dot on the census van, on the census board, but that's on teletracking.
It's on teletracking now.
Yes.
Yes, it
So
used to be.
we don't put that on the census board. We encourage the patients to call, don't fall. All right. Sometimes I say it backwards, fall, don't call, but that's a slip. We want to staff your name of patient during toiletry. So don't just put them in the bathroom and then go back to the nurse's station down the hall. It's like, they're going to call me. Will they? I mean, sometimes they're going to go ahead and get up and go back, and that's when they're going to fall. That's when most of our falls occur. They're trying to go to the bathroom. All right, so place that personal alarm on the patient. This is a POSI alarm, and there's another piece that goes to it. So there's a piece that you can put underneath them so as they try to get up, and then that is a part that alarms. Educate the family and the patient to increase risk. Consider a dietary consult for appropriate nutrition. Maybe they're really weak. All right, for high fall precautions, we can utilize the Reduce Your Risk of Falls letter, utilize bed alarms, recommend the family or friend to stay with the patient, toileting rounds. This is back to that hourly, if the nurses are doing the hourly rounding, the PCTs are doing the hourly rounding, we should be taking that toileting rounds. We want to move them as close to the nurse's station as available. I mean, sometimes that's kind of like, well, if they're confused, they need to be close to the nurse's station. We want to use a low specialty bed and just call 2981 and let them know that you need this low specialty bed right here. And then this is a fall mat during skills or on the unit. Every room has a fall mat. And you guys see that the beveled edges are placed facing you, and this hard edge goes up against the bed. So make sure you put the hard edge to the bed, otherwise it can be a fall hazard for the nurse or the PCT. So that's very important. And in the huddle every morning, as you guys meet, you can say, well, Mr. Jones in room whatever is a fall risk. I've been talking to him and he's trying to get up, so this is what we've done. So make sure you talk to nurse and from nurse to PCT so that you can keep him in bed or get him to a chair for a little bit. Maybe he just wants to get out of it, but communicate with everybody. So since he is a fall risk, you don't want him to end up falling. Okay, so your patient is falling. So now what do? You have to call a code goal, and then the fall response team will come. And of course, provide immediate response to your patient, immediate care, and then reassessment, escalate the interventions. So if your patient was a low fall and they fell, Well, now they're gonna be moved up to medium. If they were a medium on that bill, they're gonna be a high. And then you have to document the patient's chart, complete an incident report in accordance with the hospital policy, and we'll show you guys exactly where to find the policy, so you can find the IRS report. Communicate all to the admitted provider and family, and capture the high alert in the daily total. Okay, now we're moving into pain management. There's only one question on their Press Gaming survey that they get, but pain is something that the patient says. How often was your pain well controlled? Of course, she says my pain is not well controlled. How often did staff do everything they can to help with your pain? So pain is something, I mean, I could be standing up here and I can tell you guys I'm in a 10. I have pain in a 10. Do you guys know that? You don't. You just have to take my word for it. So it's really whatever the patient says it is. So on that new communication board, we're going to remove the Long Baker scale, and we're just going to ask them a little bit about their pain. We're not negotiating pain anymore. I know some of you have probably had that patient's like, I'm a 4, and I need my IV dilaudid like right now, and I need it every 30 minutes. Well, we want to take the emphasis off that. We don't want them to hurt, but pain is what they say it is. It's not something we can see. So we're trying to, the Center for Medicare has de-emphasized that. So on admission, we assess their pain. Every 4 hours, we're still assessing their pain, and then as needed. Before an intervention, we assess their pain. And then if I'm telling you, I'm a 10, I need some pain medicine, well, give me something, whatever I have ordered, and then come back and check it again in an hour. Did it help? If you only give me a Tylenol? And one of the things I like to say about this is like when my 82-year-old mother was in the hospital, she had just had surgery, and she was out in her room, and here came 2 nurses, and they had her PCA pump, and I said, whoa, what are y'all doing? They said, well, she's in pain. And I looked at my mom, and I said, are you hurting? And she said, no, I just got to go to the bathroom. And it's like, well, how bad are you hurting? Because they're getting ready to hook you up. She takes no medications, none at all. She takes a lot of over-the-counter herbs, but no medicines. And they were offended that I was asking them to take it away. And my mom said, well, can I have a Tylenol? And they're like, well, yeah. So they took back the PCA pump. They took away their medicine. And then the doctor came in and said, well, you know, are you sure you're not hurting? She's like, yeah, I just need to get up. And he said, well, you can't get up. You have to stay bed rest for so many hours. But you can have a Tylenol. So, I mean, sometimes we want to overshoot that pain because there's no telling what a PCA pump would have done to her. Being her age, yeah, no medications.
She probably would never have pushed it.
No.
They would have got a full syringe by discharge.
And they made me feel bad for saying she doesn't need it. But I thought.
But you know your mother better than the nurse does.
Yeah. So, like we said, patients defined by whatever experiencing person says it is. Patients can expect that their healthcare providers will involve them in the pain assessment. Let's see. All right, so this is the screen that's going away from the patient's room. So we're not really negotiating like their pain goal anymore. We want to take care of their pain, but we're not going to go into this. Well, you'll take a 4, right? Right? We can agree on that. So we're going to kind of back away from that. We want you to be, you look like you're fine. So you say you're not hurting, so that's it. We're just going to move along. All right, so hospital-acquired pressure injury. So when you get a new admit, please look at their skin from head to toe. Because if they have any bruising or anything, and you don't document it, then we own it and we will not get paid for that admission. Even if, and like the wound consult nurses, they're getting concerned because there have been a few patients that they get consulted on The patient had like an AKA, a BKA, and a wound vac that wasn't connected to anything. Well, they only got consulted for like a BKA. And then when they got in the room, it's like, well, we also have an AKA and we have a wound vac, and it's not connected to anything. So is it supposed to be connected? What's underneath? We've got to look that over. So it's like, just if you're going to consult the wound care nurse, and we have 3, just let them know this is the full picture. So it just made her question, like, did the nurse really look the patient over from head to toe? And I want to go to the defense of the nurse and say, sure, she did. Of course they did. Why they didn't mark all 3 of those, I can't tell you. But it is kind of like, if they have a wound dressing present on admission, make sure you remove it. Like that wound vac, that should have been removed to look and see what's the skin look like. Because any kind of breakdown, that's on us if we don't know that it was there.
And does a physician even want them to still have the wound vac?
That's an excellent question. We've got to call and find out. Oh, you wanted a wound vac. Okay, well, we can continue that. Exactly. And then implement the plan of care appropriate for skin breakdown. And if you need to, you can take a picture with like the wound camera. So to prevent pressure injuries, make sure you turn your patients every 2 hours. Inspect those pressure points for signs of redness. And with the PCTs, as the PCTs are turning them, if you see like a bruise or a pink area, please tell your RN, because maybe she has seen it, maybe she hasn't. But just communicate with her. And then if she says, or he, and if they say, oh, yeah, I saw it, great. If they say, no, I didn't, then keep them informed, okay? Because the PCTs may be the one providing the skin care with lotion. Cleanse the perineal skin areas, bridge the heels with pillows, and then when the patient is sitting up in a chair, limit the time to a 2-hour period. I worked at a facility for physical therapy. They love to get my patients up, and they wanted them to sit in the chair for 8 hours. Sit for 8 hours. You cannot get down. They're back in bed. And I would have to argue with them. It's like, well, they're sitting there. We've got to get back to bed because they were weak. So we kind of had that round and round circle. All right, if you need one of these waffle mattresses, you can call the number that was before 2891 and just tell them that you need a pressure distribution mattress, a waffle mattress. That's the name I know it as. All right, so all interventions will be documented in the patient's medical record. So if they have some sort of a pressure injury, you're going to document it, you're going to update the plan of care. If a hospital-acquired pressure injury is identified, you want to notify the provider, you want to consult the wound ostomy nurse, you want to document the assessment and stage in the patient's medical record, and then you have to complete an incident report. Because if it happened while they were here, we have to complete that incident report so we can figure out what happened. Did we not have enough staff? Did we not turn them often enough? What was the breakdown that we didn't deliver good care? Implement additional interventions as appropriate, if you will. Now, restraints. Patients have a right to be free from restraint or seclusion. Restraints are never your first choice. I know there's once in a while that patient, you're like, boy, how do you just put them in restraints? No. All right, we limit the use of restraints or seclusion to only those clinically appropriate and adequately justified. All right, so these are all the alternatives that you would use before you put someone in restraints. You want to talk to the family and educate them. Calm, low environment, maybe dim the lights. Maybe they need the lights on, depending on the situation. Maybe they're in pain. Give them some Tylenol, something for the pain. Make sure they have their items in reach, because if they're trying to get to their classes or their cell phone and they can't reach them, maybe that's agitating them. So move that closer. Maybe you can move the room close to the desk. Reorient them. Like, remember, you're here at St. Vincent. Monday, and just reorient them and make sure they know where they're at. Maybe they want to hear some music. Maybe the music's on, or they want it off. So see what's going on there. You could use a sitter. You could do that one-to-one staffing. We could put them in seclusion in lieu of physical restraints, but that's only going to be on our behavioral floors. I mean, we're not going to be able to do that in the search floors. Okay, so we have two types of restraints. We have non-violent, non-destructive, self-destructive restraints, and the violent, self-destructive behavior. We only cover in orientation the non-violent, non-self-destructive restraints. Those are the restraints that we use to keep a patient from harming themselves. Like if they're on they have, it says tubes and lines. I always think of like an NG tube or a Foley catheter or something like that, and it's really bothering them and they get confused and they're trying to pull it out. They're on a vent. I want to restrain them. The violent, self-destructive behavior, those are going to be used like in the emergency department. Maybe they're coming down off something and they're trying to like clean out the emergency department, but we don't cover that a whole lot. They'll cover that in the emergency department. Okay? So all restraints, the order must be renewed every 24 hours. Okay? Do you have a question? You look like you do.
No,
Not yet? Okay.
Not yet.
Okay. All right, so restraints are not to be used for punishment, coercion, discipline, or retaliation of the patient or for staff convenience. So I know no one has ever used restraints for staff convenience, and you're not going to here, okay? I know that thought has crossed your mind, but don't. We do not use safety beds, the vest torso restraints, leather restraints, or 4-point restraints, okay? Because if they're trying to pull at their tubes or drains, it would just be like, if I have a NG tube, I would just restrain this hand, and I should be okay because I'm right-handed. And you might have to do 2 points, but probably not. Restraint or seclusion must be discontinued at the earliest possible time. So if I'm trying to get my NG tube out, you would get a restraint. You talk to me, you play music, and it's just not working. I want the NG tube out. One thing you can do is call the doctor. You know, is the NG tube, is it time for it to come out? And if he says, no, she needs it, well then, okay, I need to be restrained. But talk to me and see if you can get me to calm down. And if you can't, then restrain me. And then once you get that order, it's good for 24 hours. And then you have to take my arm out, my wrist out restraints every 2 hours for 15 minutes and check for circulation, do I have a bruise, and see if I'm in pain, do I need to go to the bathroom, do I need to be repositioned, and things like that. Okay, so jerry chairs with an attached table, that's considered a restraint. The side rails times 4, that's a restraint. These mittens that attach to the bed, that is a restraint. And this restraint to the bed, that is a restraint. Yes, ma'am?
Is medication considered a restraint?
Yes, there are, if you use it as a restraint. That's like if you have Ativan to calm, depending on the order, but if you're using it only to relax me, only to like get me to be quiet, then it can be used as a restraint. Does that make sense?
Mm-hmm.
You have to use it within its appropriateness.
If I use that, am I allowed to use any of these other restraints at the same time?
You can. It has to be very carefully documented. I mean, you can't just say, medication given, restraints. You can't do it back and forth. Because really, if you've given me, before you put me on restraints, if you've given me a dose of medication, and then you put me on restraints, then you should not need to continue to give me medication.
Right, so like the least restrictive method.
Right, the least restrictive. Right. All right. So, steps to proper documentation of restraint use. So you want to document the alternatives used prior to restraint application. document the patient condition and why you put them in restraints. You don't want to just document patient put in restraints. You want to monitor and document appropriately per the type. Restraint seclusion must be discontinued at the earliest possible time, regardless of the scheduled expiration of the order. Because that order is good for 24 hours. So maybe in 12 hours I've calmed down. That adamant you gave me earlier and the restraint is like I fell asleep, I relaxed, came in. So maybe I don't need it anymore. When you came in to check and took it off and you talked to me, it's like, I feel fine, I don't need, we had a good conversation. Then that's it. You can take them out, you can discontinue them. You don't have to keep me on that restraint for 24 hours. And then keep updating the clinic care. And I also, just remember, like if I'm confused, because we had a patient, he was very confused, there was a chair and he wanted to go out through that door. For some reason he thought that chair was a door. So because he was confused and he was trying to hit people to protect himself, the nurses, they wanted to document that as violent restraints. He wasn't trying to hurt anybody, he was trying to protect himself. So that was nonviolent restraints. All right. So, results of the patient experience survey will determine 25% of our reimbursement. So this is back to what we talked about at the very beginning. The communication with the nurses, communication with doctors, responsiveness of the hospital staff. There's only one question about pain management, communication about medications. There are questions on there about this is a new medication. Did you understand the possible side effects? This is your discharge instructions. Did you understand? There are 2 or 3 questions about hospital cleanliness and whether or not the hospital looks quiet. Discharge information, and there are several questions like, I understand my diagnosis, I understand. I don't remember exactly how the questions are answered. They don't let us look at those and examine them. And then we get care transition. There's some questions on that and just overall rating. And we want them to answer always. Like my medications were always explained to me. The hospital was always explained. That's our goal. And it doesn't take much. All right. Any questions?
I have a question about the side rails. You said we can't have 4 side rails up.
Yes.
Because that's a restraint.
Yes.
How many side rails can we have up?
You can have 2, and then if you need a 3rd one to help the patient move, the patient wants to help move, 3 is your max. If you put that 4th one up, then you have them where they cannot get out of bed.
Okay.
So you can also have them sign a contract. I have to pull it and look at it. Because like if they're waking up in the middle of the night and they're trying to go this way and the bathroom's that way, and you've talked to them about using the call light, you can put this side rail up to keep them from going that way. That 3rd one, but you need to really have them sign like a contract.
I have a question. Do you have to have an order to get a sitter? Or can I just get somebody to come sit instead of putting them in restraints?
You can just get someone to come sit. You can. And we would love, of course, we would love for it to be a family member to sit with them. A lot of times they'll respond better to the family. Of course, there are times when we can't have family. We have to have, it's normally a PCT that will sit. So,
What about the mitts? If I don't tie them down, do I still have to document those as restraints?
no, we actually have submits, and I wish I had one with me, that they wrap around, and there's no way to connect them to the bed. And those are not a restraint. They agitate the daylights out of me, but they are not a restraint. Yes?
Yes, I have a question. I've worked in different facilities before, so if you put the patient's bed alarm, if you engage the bed alarm, is it connected to the call-out system or on our Coursera? Would it trigger if the patient get up off the bed? Would it alarm on the nursing?
Yes, it does alarm on the nurses. They call out. Yes. It's a very good question. Yes. Thank you all and welcome to CHL. We're so glad to have you. Thank you.
Thank you.